What I focused on today is the current state of the field of using CAR T cells for ALL. So I think we're at a point in the field where we've shown across many different clinical trial platforms and now in the commercial setting that CAR T cells are efficacious in terms of delivering high response rates for patients that have relapsed and refractory disease. And what I wanted to focus on is where we are now in terms of moving the field forward. So I think there's two key focuses in terms of real-time movement of the field forward. One is to improve our ability to mitigate toxicity. And so there's many strategies that are being employed to try to reach that goal. One is delivering the anti-cytokine-directed therapy Tocilizumab earlier in the clinical course of CRS. Another approach is to modify the dosing of CAR T cells, either in response to early toxicity, that would be like a fractionated dosing scheme, or giving an inverse dose of T cells in response to toxicity. So that's kind of one aspect, which is improving the way we prevent and deal with toxicity. The other is we know that initial response rates are very high, but what can we do to improve the long-term outcomes for patients? So what can we do to learn more about minimizing the risks of both CD19 positive relapses, and that often correlates with the persistence of the T cells, and what can we do to decrease the rate of CD19 negative relapses? And that might employ including another target for the CAR T cell, such as CD22, or combining CAR T cell therapy with other targeted therapeutics.